And lastly, let's take a look at preventing missed opportunities. Okay, so when we looked at the MDS coding sections, we learned that one diagnosis can make a big difference. And one way to thoroughly review a record is to look for particular items, okay? And so perhaps maybe in your next review, consider saying, okay, now we're going to review the diagnosis list and consider what are common comorbidities and complications that frequently accompany these diagnoses. So for example, when we look at, let's say you have somebody that has a diagnosis of ALS or amyotrophic lateral sclerosis, right? But there's no swallowing problem or there's no mechanically altered diet. And you say, well, not all folks have these issues, right? It is a progressive neurological disease, so maybe they haven't manifested yet. But and that is absolutely possible. But by the time a patient, usually gets admitted to the facility, you're seeing a lot of these comorbidities already in place. A lot of those folks and because they tend to be a younger population, tend to stay at home as long as possible. So, but again, it's food for thought that I want to provide you today is start thinking about it from kind of a reverse look, is not just looking for the diagnoses, but also looking for common comorbidities. Same thing with CVA. If it's an active diagnosis, right, it's not an old CVA that really doesn't have any, lingering effects, but we're talking about an active diagnosis of a CVA where there is no hemiplegia or hemiparesis or swallowing problems or possibly even cognitive impairment. And again, that doesn't mean they have to have these, but again, looking at them and saying, if they do, did we capture it? And then flipping that around. Perhaps you have a comorbidity, but you don't have the diagnosis. Okay, you'd be surprised how many times we do see this in our data integrity audit, right? We see these, and that's one of the algorithms that we put every MDS through, is looking for these, that you have the comorbidity, but you don't have the diagnosis. So diabetic foot ulcer without diabetes, not likely, not hemiplegia or hemiparesis without a CVA or other, likely diagnoses. Again, there certainly can be other reasons for it, but again, cueing you into those common scenarios that are there. Or possibly looking at this from this angle, treatments without a diagnosis. So you had isolation without a multi-drug resistant organism, right? That could be one thing. Suctioning without a trach, ventilator, COPD, or pneumonia, et cetera, right? Looking for those other reasons why that suctioning might be there. Or insulin injections without diabetes. And again, we've seen all of these occur. So, and we know that it's easy to miss these things, right? These are especially, as you're doing multiple MDSs at a time, or you had a rush on admissions and you're working through many of them. So these things are very easy to miss. And so again, doing this review possibly as a team or in your weekly meetings can also make sure that you've got the most accurate MDS possible. Okay. And again, documentation impacts the NTA comorbidities, right? Making sure everything's diagnosed, everything's you have as a diagnosis are documented. One of the things, body mass index is a good one. If you've got it over 40, check for morbid obesity. And so then, and this is a good one to look at too, because, when you look at how the National Institute of Health defines morbid obesity, they say either 100 pounds or more above the ideal body weight, a BMI of 40 or greater, or the one that a lot of folks don't necessarily realize is they can have a lower BMI, possibly 35 or greater, and one or more comorbid conditions. So let's say they have diabetes or heart disease or other. And so that a diagnosis of morbid obesity could be present on the record, and maybe you're not realizing it, or it might be somewhere from the hospital where this information is living and you just haven't found it yet. Immune disorders are commonly overlooked. Checking for opportunistic infections, and in that, making sure that documentation, you want to make sure you have the organism in the site. If there's somebody's ventilator or respirator, check for diagnoses of respiratory arrest or cardiorespiratory failure. And then end-stage liver disease. Go back and look and see if there's any evidence of cirrhosis of the liver, okay? But it's important to really look at these and know which diagnoses qualify. Okay, here's an example of the of the NTA component and the ICD-10 codes that that qualify. You know, there's several codes that are available, but again, if you go to the mapping, the ICD-10 mapping that CMS provided to us early on, right? And here's the link where if to get to that, if you have not seen that, and use filters. You know, filter out by morbid obesity and seeing where they stand. And here you see. We've got E codes and Z codes, and the obesity due to excess calories right here. And these are the ones that qualify for the NTA component. Okay, if it's anything else than this, then it will not qualify. Another really good example of this we see very frequently on our with our data integrity audit is that, oh, I have R13 coded on MDSI 8000. Why did I get this trigger in the data integrity audit? Well, R13 has to do with signs and symptoms involving digestive and abdominal disorders, right? So it's a different category. But see, if you go again back to that mapping, that crosswalk Excel spreadsheet that I just showed, if you look here, the only diagnoses that qualify for the SLP-related comorbidities are the I category, I69, which is under cerebrovascular disease. Okay, and so these are the ones that you have to have coded in I-8000 to get that comorbidity. Okay, so very, very important, and we see this quite frequently. You know, looking at ways to capture swallowing problems. You know, a lot of folks just rely on the documentation, so as if they have an existing swallowing problem, or hey, you know, we've got a diagnosis, that's all we need. But really, you know, this particular area is based on section K 0100A. And so, you know, a lot of times folks are coming in, if they come in from the hospital, they're debilitated, right? Especially if, you know, if they're coming in from, you know, from the hospital with recovering from COVID, they're going to be very deconditioned, right? And swallowing can be a real chore and just very exhausting, right? So you might see, and so this is where CNAs are going to come in very handy and looking for these symptoms. Did you notice any losing of fluids when they were drinking, either liquids or solids? Are they, when you take them back to the room, have you found, you know, food remnants still left in their mouth? Maybe during meal pass, asking all 3 shifts, or if you're giving meds, are they choking when they're trying to swallow their meds, or sputtering at meals? You know, yes, there might be complaints of difficulty swallowing or pain, but you know, this is usually something I don't know. Remember that I heard this a lot. You know, patients, this isn't something they complain about frequently. They may just realize this is part of normal, or they may not even realize they're holding food in their mouth. So watch several meals, observe, screen residents, and watch for changes over time. Just because they didn't have it when they came in doesn't mean they're not going to have it going forward. Okay. And again, diagnoses, active diagnoses, I think folks are getting much better at that. Second bullet here is really important. Use your checklist first. Some of the NTA diagnoses only count if the checklist item is checked. So a good example of this is diabetes at I-2900, okay? You can say, oh, I had it coded in I-8000. But it's no, this is really important that it be coded as CMS shows us of where they're pulling them from as well. Okay, and so if you have any questions, refer to the RAI manual, chapter 6, and there it's all laid out there. And again, going back to that ICD-10 Excel spreadsheet, the crosswalk, the mapping, you'll be able to see that very easily. Okay. You know, when you're looking at depression symptoms, you know, look at the end splits, you know, and see, look at the financial impact here. These affect 3 case mix groups for nursing: the special care high, special care low, and clinically complex. And if you look over to the right, you can see the difference that depression will make. And so if you're missing out on somebody that does have depression, you know, you're looking at a difference of $42.37 per day for this first special care high, right? And it goes all the way, it ranges all the way from $14.83 to, looks like 42 is the highest here. So that's a pretty big range, and again, that adds up over time. So definitely something to make sure that you're accurately capturing depression. Looks like everybody's doing a lot better with it, but again, making sure that you've got everyone that should be recognized as having these symptoms, and making sure that the care plan shows those interventions. Cognitive and mood interview, best practices, right? Looking at different ways. Speech language pathology can give you guidance on good ways to communicate with residents. If they have a communication deficit, but they're still understanding, and in B0700 and 800, if you're still coding that they have methods and can communicate effectively and do understand you when you're talking to them, making sure that when you're doing the interview, even if, let's say, they can only answer yes, no questions, that's where the cue cards come in handy. And all these alternate methods of communication are very important, because really CMS, our charge or our challenge from CMS is to capture resident voice, not what we think the resident voice is whenever possible, right? So everyone should have this attempted. And so looking at alternative ways to communicate with those residents that might have challenges. Social services can certainly help us with some guidance on interviewing techniques. There's some great videos that are put out. I put resources on the last slide that have links to those. So if you're new to these or need a refresher, these are great resources. If you're in the MDS world, if you're the coordinator, you're the expert in the RAI manual. You be the expert for the rest of the interdisciplinary team and make sure that they're following all the RAI manual instructions for the resident interviews and the staff assessment that are in Appendix B. And make sure that the assessor knows the assessment reference date so that interviews are done timely, right? This is another key area that I know a lot of folks struggle with, is getting them done timely. And again, under missed opportunities, another area to look at is your IPAs. This is involved where there's at least a change in one component so that a resident would be classified into a different case mix group from the initial Medicare assessment. And so it's important to know that not every change in a resident's condition is IPA worthy, right? You have to understand the payment drivers in each of the categories that were captured on the initial assessment and consider, is this going to change the case mix group and warrant an IPA? Well, again, which could mean, if you don't look at them, this could be a missed opportunity. Again, don't forget the emergency room visits. If treatment's given during an emergency room visit of less than 24 hours, right, if they're in there real quick for observation, even if the resident wasn't, especially if they're not admitted to the hospital, right, which is a key point to point out here, these count as while a resident. So they may qualify an IPA if the criteria are met. So look through that. Look through the documentation from the ER. Was there a transfusion? Did they have IV meds or IV fluids? Did they do suctioning? Was oxygen provided? All of those things are important things to look at that may certainly impact the case mix group. Okay. So let's do a couple of examples here. I know we've just got about 10 minutes left here, but let's look at, just to quickly go through these. So if you have a nursing case mix group is currently special care high, and they develop fever with pneumonia with fever on day 12. Okay, this is certainly a scenario that could be happening now, right? Would this, be worthy of an IPA? I don't think so. You would not have a change in the case mix group because the pneumonia and the fever still is in that special care high category. Well, let's say that you did a COVID test and they came back positive and now you need to put them in isolation. This would definitely change that story, right? Okay, so there's certainly an example of something that could happen today. So let's look at this one. This one where you have an NTA with a case mix group of ND. The score is 5. We've got COPD, diabetes, and morbid obesity. And on day 8, you see a diabetic foot ulcer. It's documented as identified. And you say, okay, is this something that is IPA worthy? Yes, this absolutely could be IPA worthy because it changes the NC group. Changes the case mix groups to NC from ND, and therefore, because the score is now 6, so certainly changes that and could be IPA worthy. Let's look at a last one here. A PTOT case mix group is TF, where you have a function score of 7. But by day 7, the mobility has definitely improved to their partial moderate assist, they transfers, and walking with substantial assist, okay? It's on day 7. And so you say, okay, is this IPA worthy? Yes. Why is that? Well, this would change the case mix group to TG. You'd have a new function score of 10. And so, and the PT and OT variable payment adjustment is not in effect yet, right? We're on day 7, and that doesn't go into effect until after day 20, right? So definitely this could be IPA worthy. Okay, so like I said, as I mentioned earlier, the references to the websites I referred to. Again, the first one is where you can find that ICD-10 crosswalk. If you're just not sure about the diagnoses, you think you have them coded right, and you think it should qualify for a particular case mix group, but yet it's not showing up that way. This could be a good resource for you in terms of why that is not triggering. And again, if you're a PointRight customer, that's something we provide for you in our data integrity audit. We're giving you those PDPM reimbursement alerts. And so watch carefully for those, because a lot of those same things that I shared with you today are covered in those alerts. Here's CMS training videos related to the training materials, and the mood assessment and the videos for interviewing vulnerable adults. Again, these are great resources that, especially if you have a new interviewer, and go from there.